It's my great honour now to introduce our international guest speaker. We are really fortunate to have Professor Madhukar Trivedi join us today from Texas, I think, is where you're sitting at the moment. Professor Trivedi's very impressive CV is available to you on the program. He's currently the Professor of Psychiatry and the founding director of the Centre for Depression Research and Clinical Care at the University of Texas Southwestern Medical Center. And the reason that he has kindly agreed to come today to our session is to present some work, one of the very few positive clinical research pharmacotherapy findings in the area of methamphetamine use disorder earlier this year with the combination bupropion naltrexone intervention. So we will have a very brief rapid fire session from Dr. Trivedi of 7 minutes and then 3 minutes for questions. So please put your questions into the question and answer session so that we can have a very lively debate at the end and then let Professor Trivedi go home after what must be a really long day. Thank you, Professor Trivedi.
Thank you so very much, and I'm very excited and pleased to be there virtually. I would love to eventually someday visit you guys. So thank you for organizing this. I think as you all highlighted, methamphetamine use has been a major concern, and in fact in the US and world over, but in the US, rates of use of methamphetamine and unfortunately fatalities over the last 5 years, especially in the last 2 years, has increased tremendously. And unfortunately, we do not have any medications approved for the use of methamphetamine use disorder. There is contingency management that has been shown to be efficacious. Its widespread use has been unfortunately limited. So we really should be thinking about promising candidates. And there is been a lot of research in this area, and that had some issues, and so I'll talk briefly about that. So we decided to actually think of it like any other serious medical illness and say, maybe there is a way to think about combination medications to try and address the efficacy issue, and then put in some study design aspects to see if we can actually begin to have some signals. So as you all know, there has been a fairly large number of pharmacotherapy studies done. Unfortunately, if you review these lab-based studies as well as clinical trial studies on both actually methamphetamine and cocaine, we find that the studies are small. The studies have poorer retention and not full completion rates, and that has really hampered its real widespread use. And unfortunately, there is a chicken and the egg problem because these studies have not produced efficacy. Pharmaceutical industry has also been slow to start investing in it. So my hope is that this initial study that Nadine talked about and its results may give us at least some incentive to start thinking about it. In order to address problems related to previous studies, what we decided to do was two things. One is first, one of the things, real challenges, especially because of the heterogeneity of the use of methamphetamine in real practice. There are some people who use it on weekends, some people use it all the time, but then stop, etc. We wanted to ensure adaptive study design was used, and then the SPCD, or the sequential parallel comparison design study we used, has the other added benefit of being efficient in terms of trial duration. So our trial was actually 2 phases of 6 weeks each, rather than a long trial. It reduces cost and actually exposes fewer people to an investigational treatment. We did focus extensively on trying to ensure medication adherence, and we got much better results in terms of maintaining adherence both to the treatment and retention in the study. And the population we studied, I'll talk to you briefly about. What we thought about doing was combining 2 theoretically at least available options. One is naltrexone, which does appear to reduce reinforcing effects of amphetamine, reduce likelihood of relapse, and most importantly, decrease craving. And then bupropion to reduce Q craving and decrease meth use. And in both cases, what we decided to do was really go aggressive in the dosing. So for naltrexone, injectable naltrexone, we used every 3 weeks rather than every 4 weeks. And then bupropion extended release, we went all the way up to 450 milligrams a day. and used this sequential parallel comparison design. If there are questions, I'll discuss the benefits and cautions about this study design. Suffice it to say that this study design has been used in other medical conditions like depression. And so we borrowed that and brought it to this, where the sample size we studied was 400 plus subjects. The participants who really helped us do this study included majority, 2/3 males. Mean age was about 41 years. The key issue is the baseline days of methamphetamine use was 26 days. So you can see that the sample we ended up with was a population of people who were using it almost every day. And the way we had accomplished that was we asked for people who were heavy users, and we did urine drug screens 3 times in a span of 10 days, and people had to have 2 positive urine drug screens in that 10-day period, plus a positive urine drug screen on the day of randomization. These are the results. We found that the placebo response reduction that we were aiming for was accomplished. And so in stage 1, our response rate, abstinence on placebo was 3.4%, and in stage 2, 1.8%. And the corresponding response rates for naltrexone plus bupropion were 16.5% in stage 1 and 11.4% in stage 2. This study design uses a weighted average. And so if you look at the weighted average across the 2 steps, the combination weighted average response rate was 13.6% versus 2.5% for placebo. A number needed to treat of 9, which is really in the range we would want for clinical practice change. The results were consistent across many domains, including timeline follow-back that was self-reported, craving scale, cigarette abstinence, as well as depressive symptoms, all showed similar pattern for the combination versus placebo. So the consistency, including subgroups, age, gender, race, ethnicity, all showed similar effects, and none of them showed placebo to be any superior to the medication combination. So just again, in the interest of time, I'm going to wrap up, but when you compare it to the other positive trial, which is small, but at least had positive effects, were mirtazapine trials by Phil Coffin and the group. And their effect sizes was about 0.11. Our effect size was 0.32, which clearly is in the range that one would say is effect large enough that one would think of improving or changing clinical practice. So I'm going to stop in the interest of time, and hope I didn't go over, Nadine, in terms of the time.
Perfect. Thank you very, very much. It is really quite exciting. I've got a number of questions, but I'll start with one of the questions that's been posted here by Tony, and he's asking, given the doses of bupropion used, were there problems with side effects as they can limit the acceptability of this drug for patients?
Thank you. And I think that's a very valid concern, and we were starting to work with that concern. But I think if you look at our publication in the New England Journal, we did not run into trouble with that, actually. We gradually increased the dose from 150 to 300 to 450, and we had allowed for provision to be able to back down if needed. So we were actually able to have very good acceptability on the part of participants.
Mm-hmm. And I guess I personally have a companion question associated with that. On the naltrexone component, you're probably aware that we don't have the injectable depot preparation of naltrexone here in Australia. So if we were going to do some kind of replication study, we'd have to use the oral formulation. And there is some concerns again about acceptability to clients about that drug. So I wondered if you had any comments on that for us.
I think both the bupropion dosing, because I bring my experience from depression, so therefore I was wanting to be higher dose to 450, and same thing with naltrexone injectable. And I think it had 2 issues. One is the every 3 weeks, and the bigger issue that you're raising In using an injectable, I think we got benefit in terms of adherence.
Mm-hmm.
So that is the only difference, but otherwise delivery of naltrexone probably shouldn't make a difference in terms of pharmacodynamic effects. It's the issue that if you give oral, there might be days when people don't take it and might affect efficacy.
And did you have any qualitative feedback in terms of acceptability of the two drugs to the participants?
So we did not do any elaborate qualitative analysis, but we did not have any major differences in dropout from the combination versus placebo in the study.
Mm-hmm. Okay. I also have another question. You did mention that you might be able to give us some more cautions and benefits on the sequential parallel study design. And I guess the quick question is, would you use that method again? Would you do it again? I don't have personally any experience of doing a sequential parallel study design, but it is obviously of interest. I mean, anything that shortens duration now. We've been working on the lisdexamfetamine for methamphetamine study now for years. COVID is only partly responsible for the duration there. So would be interested to hear if you do it again and if you had any cautions and benefits you'd like to share with us.
I think the one caution, or not, it is a caution, but I think it can be overcome easily, and that is the parameters that you use to define how you will move from stage 1 to stage 2. That is, we used week 5 and 6 in stage 1 and the response that participants had to determine if they got re-randomized in stage 2. Those parameters, we had to maintain blinding. So we were actually very articulate in not giving that information to the investigators and the participants. So they did not know when we will re-randomize. And so blinding is the main caution to keep in mind, in my view. Otherwise, I like this study design. We've used it in depression, and now with this trial, we were able to actually, and you could see the effect. The placebo response is so minuscule that we were able to accomplish that. So I would use it again. There are other alternative adaptive designs available. People use placebo run-in, treatment run-in, or a predetermined adherence marker so that you have kind of a ramp-up design where you treat people, assess their adherence, and those who are non-adherent, you are a priori not included in the analysis. All of those could be used, but I like this. Part of it is I am biased about it. We like it.
And in terms of people interpreting the results, you didn't have any problems with people accepting that as legitimate?
So I had a lot of discussions, and yes, it was seen as ultimately legitimate, but we had a lot of discussion with the FDA, with the sponsors, with the DSMB, with IRBs. So I think that that took some effort. Yeah. I was convinced, and somebody asked the same related question, why use the combination and not naltrexone when there is some signal? If you look at all naltrexone studies, the effect sizes are at best small. Even the mirtazapine study, they're small. And we run into that with depression, anxiety, actually, where monotherapies may not be as efficacious and combinations seem to be better. So I don't buy that naltrexone alone will give us the signal, but it is possible. At least that my bias was that we'll need a combination for this. This is a serious illness.
Yeah. So that's you've answered Rebecca's question. Thank you. Jill Betty has also asked the question there about whether there was any issue with co-use of opioids with initiating Vivitrol, given that co-use of fentanyl and methamphetamine is increasingly common, as we understand it, in the US, not here.
So I think that is an interesting challenge. And when we did the study, we actually excluded people if they were currently using opioids. We did actually do a naloxone challenge to ensure that there was no problem. And in fact, after we had about half the subjects recruited, we looked at the effect of naloxone challenge and were able to convince the DSMB to drop the naloxone challenge because at that point, at least our methamphetamine users were using purely methamphetamine. I think Dr. Bedi raises the question that if we had to do it today, we may have to rethink, because now, at least in the US, there's a lot of inadvertent use of fentanyl because the drug distribution is getting laced with fentanyl. So that is something we have to think about.
Yeah, I mean, we haven't used naloxone challenge test now for decades, but maybe it needs to be reintroduced.
One small anecdote. My personal clinical experience is that there is still a sizable proportion of patients for whom methamphetamine is their preferred drug of use, and as long as there is no unknown contamination with fentanyl, then it still is their preference. At least still remains methamphetamine.
Yeah. Okay. Clinically, our experience here is that if people are knowingly using or dependent on opioids, they're not going to volunteer for naltrexone or naloxone.
Right.
There's a couple of other questions from the audience. How accessible is naltrexone and bupropion in environments where there's high population of people who use methamphetamine, like custodial settings or prisons, just in terms of disseminating this treatment going forward?
So at least, again, I know more about the US. In the US, naltrexone oral and bupropion are available in custodial settings. The injectable naltrexone still is a marketed product, and so varies in many places, and a lot of prison systems don't actually have naltrexone injectable yet.
Mm-hmm. Okay. It might be different in the
And
Australian context.
Maybe I'll share my bias about this. If this were any other medical illness, people would not be debating whether that is affordable or not, because that would be available. I think some of it is the bias against our patients.
Yeah. The fact they're in prison in the first place probably stands testament to that statement. A question from Susie Hudson. She would like to know what happens to participants after the study, and during the study, do they have companion counselling support?
So I have a purist thing about this, because otherwise it is very hard to tease out the difference. So at least our study design and our implementation did not include other treatments during the conduct of the study. So for that 12 weeks, they were not engaged in other treatments. What happens after treatment, I think what we ended up doing is basically connecting them to treatment centers or our own, and contingency management was most commonly used. And then we did our fighting with our insurance companies, and some patients we were able to convince them to let us continue. Some others, their insurance was such that they could not. And as you all know, in the US, the payer system is much more complicated, and unfortunately, that remains a challenge.
Yeah, yeah. I have a question here from maybe Jeremy Hellier. Do you have any concerns about serotonin toxicity in patients using both bupropion and methamphetamine?
That was what we seriously considered, and I think we did not see. We had done a 50 participant pilot trial where we had done injectable naltrexone plus bupropion, open label without a comparator. And so we had monitored these adverse events, especially the serotonergic effects and even some cardiovascular effects, but we did not see that as if you gradually increase the dose. We had excluded people with severe cardiovascular disease for the randomized trial.
And presumably not excluding people who are taking SSRIs concomitantly?
Yes, we did not exclude them.
Yeah. Because I mean, this question of serotonin syndrome comes up a lot, but in practice, we don't see it.
Yeah.
I guess I wanted to quickly touch on the question of outcome measures, and I think that I imagine that was a much longer conversation, but could you share with us a little bit about how you decided on the final primary outcome measure that you chose in the end, and whether in a different setting, you might select a different primary outcome measure?
So we basically got urine drug screens twice a week, and we used week 5 and week 6 in the first stage, and week 11 and week 12 in the second stage. So you could get 4 urine drug screens for an outcome for that stage per stage. And so they had to have 3 out of 4 urine drug screens that were negative for us to call them a success. And that was our predetermined a priori outcome criterion. And there, the results I showed you were based on those outcomes. My rationale for doing that was that the absence of you getting a urine drug screen because they didn't show up, etc., is always used against them. So 3 out of 4 allowed us to have that. However, when the New England Journal asked us to do, we did do a analysis using all 4. So you had to have all 4 negative. And still we found the same magnitude of the effect. The total proportion of people who responded to both placebo and combination was lower when we used all 4. But still the magnitude of the effect for the medication combination remained the same.
We're seeing an increasing trend to use change in days of self-reported methamphetamine use. Would that have been something that you might have considered, or would you feel that you need the biological confirmation?
We did the analysis with that, and we found a similar effect, again, using timeline follow back. The challenge in at least our peer reviewers, and here at least, we get a lot of pushback when we use reduction in days that is not, quote unquote, some version of abstinence. And in fact, even with these results, when we went to, when we have talked to the FDA, they're still wanting 2 things. 3 things. One is that there should be total abstinence, it should be sustained abstinence, and they want some additional evidence of its impact, like quality of life or other things. So that is where the FDA is still struggling with. They have not yet, they're willing to have a discussion about harm reduction, but they have not yet officially accepted that as a possible outcome available for meth or stimulant use.
It's surprising to us because it's such a high bar that no other medication is subjected to. I haven't seen an antihypertensive that had to demonstrate improved quality of life.
And the sustaining part is where I have a problem even more, because antihypertensives, hypoglycemic agents, insulin, nothing actually causes permanent abstinence, right? I mean, permanent recovery. Except for anti-infective agents. And so you're right, absolutely. And I think there's more discussions happening. I don't think the FDA is yet right there. One thing is that, at least when I have taught, we've had panels, etc., what has come up from the regulatory side is the following, and that is, we do not kind of have longitudinal data showing that somebody who uses methamphetamine 20 days a month now goes to 10 days a month. What is the effect, and what are objective criteria that have been shown in longitudinal studies? So one of the problem that they are at least arguing is we as a field do not have that data, right? And so that is their argument. Obviously, clinically, we all agree that you have less chance of tragedies if you use half the time.
I'm going to keep you for a couple more minutes. I hope everyone will bear with me, because Jill Betty has just put in another question that I would love to ask you, if that's okay, if you've got a couple more minutes for us. Could the data from this study be used to identify non-abstinence dimensions of methamphetamine use that reliably predict clinical or functional improvement? So tying exactly to what you're saying about the FDA accusing us of not having data that suggests that there is a benefit in reduction in use.
So we are right now, so I don't have the answer. We are looking at moderators of treatment response, and Dr. Betty is absolutely right that we are potentially going to really be able to identify strong moderators of non-response, because our non-response proportion is so much higher. Stay tuned, or let me come to Australia next week.
You're very welcome.
So we are working on that. Unfortunately, I apologize. We don't have the results yet.
All right, we've got a resounding comments here come to Australia from the audience, and I'd just like to thank you very much for staying back late and speaking with us here today. That's very inspiring for us, and yeah, maybe we will be embarking on some kind of replication study here too, so that would be great.
My
Thank
pleasure.
you very much. Thank you.
Thank you.